Okay, and welcome back to the MDA Engaged Pediatric Neuromuscular Care Seminar. I would now like to introduce our last speaker for the day, Dr. Michelle Caraballo. Dr. Caraballo is a pediatric pulmonologist and sleep medicine specialist at Children's Health and an assistant professor of pediatrics at the University of Texas Southwestern Medical Center. After receiving her Bachelor of Science in Bioengineering from Rice University, she completed medical school and pediatric residency at UT Southwestern in Dallas. She then did fellowships in both pediatric pulmonology and sleep medicine at the University of Colorado in Denver before returning as faculty at UT Southwestern in 2015. In addition to her pulmonary and sleep medicine clinics, as well as inpatient rounds for children on the pulmonology service, she helps run a monthly Duchenne muscular dystrophy multidisciplinary care clinic, which includes specialists from pulmonology, neurology, cardiology, and an ancillary support from physical therapy, dietitians, and social work. Outside of work, Dr. Caraballo's favorite hobbies are baking and spending time with her husband and her 2 young sons. And with that, I will go ahead and hand it over to you. Thank you so much for participating today, Dr. Caraballo.
Thank you for having me. Can you hear me okay?
Yep.
Great. I was just so honored to be invited to spend this time with y'all this afternoon and talk about this topic that I'm very passionate about. I see we have a small group, so I'm happy to make this as informal as possible. If you have a question in the middle of a slide and you want to unmute and ask, I'm more than happy to try to address it. And I know I'm the last speaker of the day, so I'll try to make it quick so everyone can move on with their Saturday. Let me share my screen here. Let me know if that doesn't look okay. Hopefully you can see that.
Looks perfect.
Great, thank you. So just as an introduction, you know, the respiratory complications that we see in children with neuromuscular disease are not because the lungs themselves are bad or are weak, but it's because the muscles that help with breathing and cough and all of those things become weaker over time. So these children tend to experience a very predictable progressive weakness of the respiratory muscles, which over time can lead to difficulty taking deep breaths and coughing effectively. Oftentimes the first signs of difficulty breathing we see appear during sleep, and as the muscle weakness progresses, daytime breathing difficulties appear as well. The age and severity of these symptoms depends heavily on what type of neuromuscular disease patients have, but this is an expected progression with various types of neuromuscular disease. So the normal cough involves basically 3 stages that allow us to expel mucus from our lungs. So a normal cough starts with this very deep inspiration, deep breath that opens up the airways, increases the amount of air in your lungs, and this allows for a higher speed of expulsion of that air, so coughing that air out. Very, very briefly, the muscles of the mouth and throat, called bulbar muscles, will kind of contract and close the upper airway just for a split second, while the expiratory muscles, so the muscles that help expel the mucus, contract. And this increases pressure in the chest to allow you to blow that air out at high flow rates. Children with neuromuscular disease can experience weakness of all of the muscles involved in this normal cough process. And so the various muscle weakness impairs the different stages of the normal cough. Weakness of the inspiratory muscles will limit the deep breath that precedes the cough. Weakness of the throat or mouth muscles we talked about that help close the upper airway, those are called bulbar muscles. So bulbar muscle weakness will impair the compression portion of the cough, where the pressure in your chest cavity or your thorax increases. And then weakness of the expiratory muscles makes it hard to expel air at a high flow rate, so diminishes the speed of the expiratory air. This is a snapshot of pulmonary function tests that we do routinely in all kids who are over the age of 5 in our clinic. And the reason that we don't do them under the age of 5 is just because usually developmentally they're not able to understand the concept of the testing. But we routinely do these tests every time the patient comes to the office, and it gives us an idea of how effective their cough strength is, how good their lung volumes are, how well they can take a deep breath in, blow out hard, and all of those things. So we know that viral respiratory illness can cause a temporary reduction in respiratory muscle strength in anybody, not just children with neuromuscular disease, but your muscles can get weaker during illness. And one of the main measures we look at, specifically in neuromuscular disease, is this parameter called CPEF, which is at the top here with this red arrow. CPEF stands for cough peak expiratory flow. And that gives me an idea of how strong their cough strength is. And there's pretty well-defined data in the medical literature that suggests that when this number drops below 270, that's when we should start techniques or order equipment for patients to help with their cough. Now, this 270 number is defined mainly for adolescents and adults. Kids, we would expect to have a lower cough strength, just because, of course, a 5-year-old's not going to have as strong of muscles as a grown man, right? So we would expect younger children to have lower cough peak flows anyway. One of the other markers of expiratory muscle strength we look at here are called the MEP and the MIP. So MEP here at the bottom stands for maximal expiratory pressure. MIP stands for maximal inspiratory pressure, and that's looking at how hard a child can suck in for the inspiratory part and can blow out for the expiratory part. And you can see across the board here, we have the second column here that says PRED. These are the predicted values. And these numbers are based on a child's age and gender and height. So they say, how much air would we expect an average child of this age to be able to blow out or suck in? And how do their numbers compare to these predicted values? So these are the predicted numbers here in the second column, and you can see this fourth column here is what this patient actually blew out, and then this is the percent predicted. So you can see this patient here has pretty good muscle strength. Their maximal expiratory pressure is 83% of the predicted value, which is we would consider within normal, above 80% of the expected number. Their maximal inspiratory pressure is above average for a child their age and height. So this child has pretty preserved expiratory and inspiratory muscle strength. But these are the main numbers I'm looking at when they come into the office to help me understand how strong their cough is and whether or not they may need assistance with their cough. As we talked briefly earlier, younger children are expected to have lower cough peak flows than older adolescents or adults. The normal values will vary with age and height, and there are very few normative data in children, meaning we don't know for sure what a normal cough peak flow is for a 6-year-old or an 8-year-old or a 10-year-old. The best data we have are for adults. So we use that 270 cutoff that I mentioned for adults and adolescents, but what's considered normal in a younger child is not widely accepted or known. So the best indication in younger kids for whether they need assistance with their cough is really whether they have a subjectively weak cough. So I will ask the parents, when your child is sick, do you feel like they can have a good strong cough and able to clear mucus from their throat or their lungs if they need to? And I will often ask the kids to cough for me in the office. I'll say, can you just show me how strong you can cough? And, put their mouth into their elbow and really hard. And that gives me some idea of how strong their cough is as well. And then certainly any child that has a history of frequent respiratory illnesses or pneumonias, that's likely to be a child that has impaired respiratory muscle or cough strength and probably needs assistance with their cough. Atelectasis is another common respiratory complication of neuromuscular disease. This is just a medical term that means either partial or complete collapse of parts of the lung. And it's caused by like a deflation or collapse of the tiny little air sacs, like microscopic air sacs that participate in moving oxygen in and carbon dioxide out of the bloodstream. And these little air sacs are called alveoli. And we can develop collapse or deflation of these air sacs during illness, but it can also happen because of shallow breathing over time when the respiratory muscles are weak. And it can involve anywhere from a very small part of one lung to a whole lobe of a lung or even an entire lung. And that's what I tried to show on these 3 x-rays here. If you've never looked at an x-ray before, what we're looking at here is the patients are facing the screen. So their right lung is shown on the left portion of the image and their left lung is shown on the right portion of the image. It's inverted. And on x-rays, air appears black. So the lungs should be mostly dark gray or black because they're full of air, of course. We all have a little bit of this kind of white streaky markings in our lungs, our blood vessels in our lungs, and that's normal. But when we see too much white in the lungs, that can suggest atelectasis. That can also be caused by mucus or fluid in the lungs. But this first image here is a patient that has just, you can see a little bit of increased white markings in the bottom part of the right lung here. The second image, this patient has atelectasis of the entire right upper lobe, and you can see it's a pretty well-defined line here. That's where the right upper lobe ends. And then the patient on the right has the atelectasis of their entire right lung. And this is not an uncommon finding in a patient with neuromuscular disease when they're sick. Another complication we like to look for and ask about in these patients is a difficulty with swallowing. And this is caused by weakness of the muscles that coordinate chewing and swallowing. And if these muscles are weak, what can happen is that microscopic tiny amounts of fluid or food particles can go down the wrong pipe into the lungs instead of into the stomach. And this little image is showing how the esophagus, which is the tube that carries food down to the stomach, and the trachea, which is the tube that carries air to the lungs, they sit right next to each other in the throat. And your vocal cords are what kind of separate them up here. But you could see how in a patient with swallowing weakness or difficulty with those muscles that it wouldn't be too difficult for little bits of food to accidentally go down the wrong pipe into the lungs here. And that's what's shown in the second image where the food enters the trachea by mistake. It's not usually large amounts of food like this. It's usually very, very small parts, but over the long term that can cause irritation of the airways and inflammation of the airways and predisposes these kids to illness and increased mucus production. If they do have a big chunk like this or a significant amount of food or liquid go down the wrong pipe into the lungs, that can cause a pneumonia, and you may have heard the term aspiration pneumonia before. And again, aspiration is just the medical term for food or liquid going down the wrong pipe into the lungs. Another complication that some children with neuromuscular disease develop is scoliosis over time. And this is again caused by weakness of the muscles in the chest and thorax that don't support their rib cage effectively, so that over time the rib cage starts to shift and the spine starts to shift and they develop scoliosis. I pulled these images. This is a very dramatic case of scoliosis. It's not often that severe, but it develops gradually over time. And it's not hard to imagine how this could affect the lungs, right? Because this child is very hunched over to one side. So one of the lungs becomes kind of compressed, and that causes collapse of those alveoli, or what we call atelectasis, and can cause them to have difficulty clearing mucus from their lungs. So let's shift to talk about what techniques and strategies and equipment we have to help these kids when they do have trouble clearing mucus from their lungs, what we call airway clearance. What do we have to help them with that? So this is kind of an old school technique that we don't use very often anymore because we have more advanced equipment to help with the cough these days. But this is what we would call a manually assisted cough that a nurse or a caregiver could do if the child doesn't have any equipment at home. It's almost kind of like a Heimlich maneuver. It's just a way to help the child expulse air from their lungs. So you can see this caregiver has put one hand on top of the other and placed it right below the top of the abdomen or the bottom of the rib cage. And when the person coughs, she will press in synchrony with their own cough, and it just helps with the expiratory muscle effort to help expel mucus. Now we have much fancier techniques to do basically the same thing, but we have equipment that will do this for you. This is called a mechanical insufflation-exsufflation, more commonly known as cough assist. And the term insufflation just means inflating the lungs or putting air into the lungs. Exsufflation just means exhalation or bringing air out of the lungs. And so the cough assist is exactly what it sounds like. It's this machine that helps the patient cough or helps simulate a cough by inflating their lungs, and then the machine can suck the air back out with a negative pressure. Yeah, I think it'll make a little more sense on the next page. So this machine has a soft little plastic mask that goes around the mouth and nose, and it creates a seal here. And you can see there's tubing that connects it to the little box. And basically it's just a puff of air in and then a suck back out. So it's like, psh. And we have these patients usually we have well settings and sick settings. So when they're well and they don't have mucus in their lungs, we'll just have them use the inspiratory part of the cycle to help expand the lungs and help them take really deep breaths. And then when they're sick, they can flip a switch and it switches to the sick settings, and they use the inspiratory and the expiratory cycle. So the puff of air in to help expand the lungs, and then the pulling it out to help with the cough and pulling mucus out. And I just put this example here. This is kind of our standard prescription for our patients with neuromuscular disease. And your physician or your respiratory therapist can set these settings on the machine, but we'll set the pressure somewhere between 20 and 40 centimeters of water. You can set the inspiratory time. So that means, here we have 2 seconds. So that means over 2 seconds, the machine will inflate that much pressure into the lungs and then pause 2 seconds. And then when they're sick, we also add the expiratory time. So expiratory time is 2 seconds. And we tell them to do 3 sets of 5 breaths twice a day. So they'll do 5 breaths and then take a break, and then 5 more breaths and then take a break, and then 5 more breaths. So a total of 15 breaths in the morning, 15 breaths at night. And again, when they're well, just the inspiratory cycle to help expand the lungs, and then we add the expiratory part when they're sick. What about how do we mobilize secretion? So that means when you get sick and you have mucus in your lungs, that mucus can kind of dwell and settle down in the lower part of your airways. And we want to help people move that to get it towards the center or bigger part of their lungs where they can cough it out more easily. Or if you have a suction machine, it may be easier to suck it out with the suction machine. So there's a few different techniques for this. This one is called IPV, which stands for Intrapulmonary Percussive Ventilation. These 3 devices are all different IPV machines. The red one is the one designed for hospital use only. So I would suspect most people don't have this at home, but you may see it in the hospital. The green one is the older model that was designed for home use. And then this blue one is the newest, fanciest bells and whistles designed for home use. So what this does, it has a little mouthpiece that the patient can hold in their mouth, and they create a seal around it with their lips. And it just sends these quick, small bursts of air to help open up the airways, and those vibrations can help kind of loosen the secretions and help get them out. So it's more just like a ch-ch-ch-ch. So it's much faster versus the cough assist, which is a full 2 seconds of air in. And the goal here is to, again, move the secretions from the more distal or the outside peripheral parts of their lungs to their central airways, where it'd be easier for them to cough it out or suction it out. You do have to have a patient who can understand the concept of creating a seal around the mouthpiece, and they have to hold their cheeks tight, because otherwise with the puffs of air, they just puff their cheeks out every time like a chipmunk, and that doesn't do the patient any good. We of course need that air to get delivered down to the lower parts of their airways, as opposed to every time there's a puff of air in, their cheeks just like that, which is not very effective. One of the benefits of this machine, you can deliver nebulized medications through this machine. So if your doctor has prescribed albuterol treatments or any other form of nebulized medication, it can be delivered through the IPV. And this can also be given through a tracheostomy for the patients that have a tracheostomy, which is the surgical procedure where they put the tube in the neck to help patients breathe. This is a device called a vest, and its job is high frequency chest wall oscillations, more commonly known as vest. So what this does is, you can see the tubes here that connect to the machine, and the tubes send small amounts of air that very, very rapidly inflate and deflate the vest, like 20 times a second. So very rapidly inflate and deflate the vest, and the result is these vibrations that help loosen the mucus in the lungs. And typically I have patients do this. If they need it, we'll do like 15 minutes twice a day or something like that. So the job is to help, again, the vibrations help separate the mucus from the walls of the airway, help loosen it out, again, where it can be more easily suctioned or coughed out. Most patients that I have prescribed vests for really like their vests. It's very well tolerated. It's almost like a little massage. I have some patients that tell me their kids will, or the parents tell me that their kids will ask for their vest treatments because they like it so much. So it's generally very well tolerated, as opposed to, if I'm being perfectly transparent, most people don't like their cough assist. It's not a very pleasant sensation to have that big puff of air be forced into your lungs. So sometimes if we have patients that have trouble tolerating their cough assist, what we can do is, for example, turn down the pressures on the machine to help them kind of just practice with it and acclimate to it, with the eventual goal of turning those pressures back up, because of course if the pressures are too low, it won't be as effective in helping inflate the lungs or expelling the mucus with the expiratory cycle. This I stole from an article that was published in 2017, just to give a rough estimate of how much these devices cost. As you can see, they're pretty expensive to buy. Luckily, they're generally well covered by most insurances, especially for kids with a diagnosis of neuromuscular disease. We don't have trouble getting it covered for that indication. Cough assist is usually the first thing I order, which is the top one here, MI-E, which is the mechanical insufflation-exsufflation. That's the cough assist. That's usually the first thing I order for kids when we have signs of their cough strength getting weaker. Vests, I typically don't order until they are having trouble, like recurrent pneumonias and that kind of thing. But typically we just start with the cough assist. And I want to order the cough assist before they're having issues, right? When I see that their cough strength is weaker on their pulmonary function testing when they come into the office, I'm going to go ahead and order that child a cough assist, even if they've never had pneumonia before, because the goal, of course, is to stave that off as long as possible, to put off those potential complications, the respiratory complications of neuromuscular disease. I don't want to wait until they're having issues and then order the equipment, because by then we're already behind the 8 ball. You know, the goal is to keep them as healthy as possible for as long as possible. And what about medications to improve clearance of the mucus or control of their oral secretions? Now, I just have one slide on this, and I'm going to touch on it briefly with the disclaimer that none of these medicines have been shown in clinical studies to be effective for patients with neuromuscular disease. And when I say effective, I mean none of them have been shown necessarily to reduce frequency of pneumonia, reduce hospitalizations, prolong life expectancy, that kind of thing. Now, just because they haven't been proven in clinical trials to help doesn't mean that they don't help. It just means that those trials have not been done in large enough scale or large enough numbers of patients to really be able to find these differences. So again, it doesn't mean that they're not useful medicines. It just means they haven't been shown in any major clinical trials to be helpful. And for that reason, they're really not part of any of the clinical practice guidelines for taking care of children with neuromuscular disease. But I do sometimes prescribe them in individual patients on a case-by-case basis, kind of depending on what type of issues they're having. You know, if they have underlying asthma, if they've had recurrent pneumonias, that would be a reason to start some of these medicines. So the 4 main categories on this chart here, the top one is a class of medicines called expectorants, and its job is to help with mucus hydration. So for example, hypertonic saline is a more concentrated form of saline, but because it's salt water, it kind of hydrates those secretions and can help thin them out so that the child can cough them up more easily. It's also, because it's so concentrated, this form of saline is very concentrated, it can irritate the airways and induce a cough, can cause the child to cough, which is a good thing in these cases where we're trying to get them to clear mucus. Sometimes I have parents that say, I don't like hypertonic saline because it makes my kid cough. And I'm like, I know, but that's the point of it. That's what we want it to do, is make your child cough when they're sick to help clear their mucus. The second category here, called mucokinetics, the most commonly known example of this is albuterol. What albuterol does in neuromuscular disease, the reason we use it in neuromuscular disease would be different in patients with asthma, for example, which is the most common indication for albuterol, is with asthma. But what it does for neuromuscular disease is that albuterol, in addition to, I don't know if you can see my hands on the camera here, in addition to opening up the airways like this, in our airways we have these very tiny microscopic hair-like things in our airways that beat like this. They're called cilia. And they're lining all along the airways. And what albuterol does is it makes these cilia beat faster. And so it can help transport mucus and move it upwards to cough it out more effectively, because it increases the frequency of the cilia beating. It also helps open airways, but that's not the main reason we use it in cases like this. The third category of medicine is called mucolytics. Most common example of this is Dornase, and also known as Pulmozyme. The brand name is Pulmozyme. Its job is to kind of thin out secretions by decreasing what they call the viscosity, which is like the thickness or the stickiness of it, and it breaks certain types of bonds in the DNA on a molecular level. This has really only been shown to be effective in patients with cystic fibrosis, so we use it very infrequently in patients with neuromuscular disease, but it's something that, you know, if we have a child in the hospital with pneumonia and they're just not getting better, this is something we might try just to see if it would help. And then the fourth category here called mucoregulators. These are medicines that help dry up secretions, so they decrease mucus production. And they're all in this category of medicines called anticholinergics. And the most commonly known, ipratropium is also known as Atrovent. Atrovent's the brand name. Ipratropium is the generic name. Glycopyrrolate is another very common one. The brand names there are Couposa and Robinol. And again, their job is to help decrease mucus production. So this is helpful in kids who they may drool a lot, for example, because they have trouble swallowing and processing their saliva normally. So their saliva just kind of pools in the back of their throat and they can choke on it. And so we may use medicines like this to help dry up that saliva. All right, moving on to talk about sleep problems in children with neuromuscular disease. Normal sleep is associated with some physiologic changes, and that includes a decreased response to low oxygen levels, and the medical term for low oxygen levels is hypoxemia, and high carbon dioxide levels, the medical term for that is hypercapnia in sleep compared to wakefulness. And what that means is, you know, when I'm sitting here wide awake, if for some reason my oxygen level started to drop, my body would compensate for that by breathing harder and deeper and faster to try to breathe in more oxygen and bring my oxygen level back up. And that natural response, that normal response to low oxygen levels is kind of blunted in sleep in everyone. Our little on a microscopic level, our receptors that sense those changes are just not as responsive during sleep compared to wakefulness. We also lose muscle tone during a certain stage of sleep called REM sleep, which stands for rapid eye movement sleep. This is the stage of sleep that we dream in, and we all lose muscle tone during REM sleep. So these are kids who are oftentimes already weak at baseline, and then they go into REM and their muscles become even weaker, and it can contribute to more breathing difficulty. And furthermore, our breathing tends to be shallower in sleep in terms of how much volume of air we move in and out with each breath is shallower in sleep than it is during wakefulness. And again, that's in everybody, in normal people. So what about in patients with neuromuscular disease? We know that neuromuscular weakness can kind of magnify or make these alterations in breathing that occur during sleep can be even worse in patients with neuromuscular disease than patients without neuromuscular disease. And this can lead to significant problems with gas exchange. And gas exchange just simply means oxygen in and carbon dioxide out. That's all we mean by gas exchange. That's the whole job of breathing. And these problems tend to get worse during REM sleep, like we mentioned, again, because of the muscle weakness, the loss of muscle tone we have during REM sleep. Kids who have scoliosis or are obese, this can even worsen these problems further just because the way their thorax curves with the scoliosis can make it harder for them to get oxygen in and carbon dioxide out. And then there are certain neuromuscular conditions that have other physical changes of the upper airway that can also contribute to obstruction of breathing during sleep. So for example, some conditions, patients are more likely to have a very large tongue, and the medical term for this is called macroglossia, or they may have a smaller or kind of recessed lower jaw, which is called retrognathia. And anything like that can kind of impinge on the airway or obstruct the airflow through the nose and the back of the throat can lead to higher risk of obstructive sleep apnea and can lead to more difficulty moving oxygen in and carbon dioxide out. So the sleep problems we see in children with neuromuscular disease can include obstructive sleep apnea, also, like we said, low oxygen or high carbon dioxide levels. They also tend to have very frequent arousals in sleep and fragmented sleep, and that means we can see on their brain waves, even for a few seconds at a time, they may wake up when we see awake brain waves, and that leads to just really poor sleep quality from the sleep fragmentation throughout the night. And to some extent, these arousals in sleep are a very healthy response to low oxygen or high carbon dioxide levels, because when the oxygen level starts to drop or the carbon dioxide level gets too high, the brain can sense that and it will wake the patient up. It'll kind of have an arousal, because when you're awake, that is more likely to restore normal breathing and bring your oxygen level back up to where it's supposed to be. So these arousals are a protective mechanism to help restore normal oxygen and carbon dioxide levels, but it contributes to really poor sleep quality in these kids. And then over the long term, what we see is that the body's responsiveness to the oxygen and carbon dioxide level issues kind of decreases over time. So initially, when the oxygen and carbon dioxide levels start to be abnormal, the body, there's a lot of arousals and very poor sleep quality. But over time, as the neuromuscular disease progresses, sometimes the brain and the chemoreceptors are less sensitive to these changes, and the patient stops having the arousals that they should have in response to these abnormal gas exchange. And so then they get better sleep quality, but we see a lot of issues with the quality of their breathing, again, restoring the normal oxygen and carbon dioxide levels. So symptoms of sleep disturbance, when I'm seeing a patient in clinic, these are things that I like to ask about. I ask every parent, does your child snore? And I want to know, if they do snore, how loud is it? Could you hear them from outside the bedroom? Can you hear them from down the hall? And I want to know, how often is it? Are they snoring every single night, or do they only snore if they're sick or their allergies flare or something? Very common for kids to snore when they're sick, because, you know, they get congested and mucousy in their nose, and so that contributes to snoring. But if they're snoring on a regular basis, even when they're not sick, then I start to worry more about sleep apnea and issues with oxygen and carbon dioxide at night. Excessive daytime sleepiness certainly is a suggestion of poor sleep quality at night. Now, the most common cause of excessive daytime sleepiness in kids is just not getting enough sleep at night. But if it seems that they are getting enough sleep at night and still tired during the day, that kind of raises my antenna a little bit as well. Daytime fatigue or tiredness, again, suggestive of poor sleep quality. Any patient that complains of trouble breathing when they lay down flat, especially flat on their back, is very suggestive of breathing difficulty in sleep. And during the day, they may have trouble with school. They may have trouble focusing, paying attention to their homework. Sometimes we see kids that are actually hyperactive, and this is all from sleep disturbance, not getting good sleep quality at night. Some kids also have mood disturbances. And any parent, neuromuscular disease or not, you know that when children are tired, they're often very difficult. They're very irritable. And then less likely, but one of the things we do look for is if the oxygen levels are low enough, it can cause seizures. So if the child is having seizures in sleep, that certainly would make me worry about some sort of sleep-related breathing disorder. On physical exam, these are the certain physical signs that can suggest higher likelihood of obstructive sleep apnea. So large tonsils and adenoids are known to contribute to obstructive sleep apnea, and that's just because tonsils sit right at the back of the throat. So if they're enlarged, they can obstruct or block off the airflow back there, and that's what's showing in this picture on top here. This is the child's tonsils, the left and right tonsil. As you can see, they are huge and basically blocking off the entire back of the throat. This is the uvula that hangs down. This is what we call kissing tonsils. They're so large, they're touching in the back of the throat. So it's not hard to imagine how that would cause obstructive sleep apnea at night. Adenoids sit kind of behind the nose. Can't see them from the outside, but similarly, when they're big, they obstruct airflow through the back of the nose. Mouth breathing is suggestive of some sort of nasal obstruction. So certainly if your nose is completely blocked off, the child will compensate for that by breathing with their mouth open when they sleep. Nasal sounding speech can again suggest some nasal obstruction. A large tongue or a crowded airway can suggest sleep disorder breathing or obstructive sleep apnea. This bottom image here is showing what we call Malampati scores. And this is just a marker of how open their airway is. and there's nothing anybody can do about this. This is just how God made you. But a Mallampati class 1, if you ever hear a doctor refer to a Mallampati score, Mallampati class 1 means a nice and open airway. Mallampati 4 means a very crowded airway, that when the child opens their mouth and protrudes their tongue, that you can't see anything except the roof of their mouth. You don't see the uvula at all, which is the thing that hangs down. You don't really see the tonsils at all because the view is completely obstructed. And patients who have obstructive sleep apnea can, over time, if it goes untreated, they can develop high blood pressure and they can also develop heart failure. So if those things are present, it makes me want to order a sleep study in these kids. So the guidelines for when do we need to order a sleep study in kids with neuromuscular disease? The suggestion is, of course, if they have any of the signs or symptoms we talked about, if they're snoring on a regular basis, if they're tired during the day, if they're having trouble focusing or paying attention in school, this would be a good reason to get a sleep study in a child with neuromuscular disease. And then with regards to their pulmonary function tests, there are certain parameters that if their numbers are low enough, we say, yeah, we should probably go ahead and get a sleep study in this child, because even if they're not snoring, their respiratory muscles may be so weak that we would worry about their ability to move oxygen in and carbon dioxide out when they sleep at night. So this is suggested for patients with an FVC below 40% of predicted. And remember, we talked about these predicted values in all kids, which are based on age and gender and height. FVC stands for forced vital capacity. All that means is the total amount of air a child blows out. And in this example, the predicted value is 2.96 liters. This child blew out 2.4 liters, total amount of air they blew out, and that was 81% of the predicted value, which is pretty darn good. But if this number were to drop below 40% of the predicted value, that's when I'm going to start thinking about getting a sleep study in this child, even if they have no signs or symptoms that we talked about on the previous slides. If their carbon dioxide level is above 45 when they're awake, it's likely to be even higher than that when they're asleep. In general, anything below 50 we would consider normal, but if it's above 45 when they're awake, it's a pretty good chance that it's rising above 50 when they sleep. And so if their awake carbon dioxide level is above 45, I would want to get a sleep study. You can see this child's awake carbon dioxide level is 31, so that's darn good. Same thing, our oxygen levels below 95 when you're awake is a higher risk of them dropping to a dangerously low level when they're asleep. So that's another time I would think about getting a sleep study. And then in teenagers and adults, they can use an absolute FVC below 1.25 liters. We don't really use absolute values in younger kids. We're looking more at the percent of the predicted values. But in adolescents and adults, we could look at the actual liter flow as opposed to the percent predicted. This is, in general, what a sleep study hookup looks like. And these are all of the different things we monitor on the sleep study. We put these little stickers on their scalp, so the tech will kind of separate the hair and put stickers on the scalp. And we are looking at their brain waves there, mainly for the purposes of telling us what stage of sleep they're in. So when the brain waves can tell us when they're asleep or awake, and also what stage of sleep they're in. We monitor, of course, the oxygen and carbon dioxide levels. We monitor airflow through the nose. So that's what these little prongs here in the child's nose, these are not delivering oxygen. These are measuring airflow to sense if he has an obstruction to airflow or a pause in his breathing. We have these soft little belts that go on the chest and abdomen. That's looking at their work of breathing, if they're having to take really huge deep breaths to achieve normal oxygen and carbon dioxide levels, or if they have decreased abdominal and chest wall movement because of their weakness. We can pick that up on the abdominal and chest wall belts. We have these tiny little leads on the outside of their eyes that are sensing eye movements, and that helps us know when they go into the certain stage of sleep called REM sleep, or rapid eye movement sleep, because the eyes move very fast in REM sleep, and it helps us identify that stage. There's a snore sensor, which at least half the time picks up the parent who's sleeping at the bedside. So sometimes the snore sensor is not very reliable, because sometimes it's not the child, but the parent who's sleeping next to the child. We have a single lead EKG that's monitoring their heart rate and heart rhythm. We monitor leg movements, looking for things like restless leg syndrome, that kind of thing. And then we also video them. So this is generally what what the hookup looks like for the sleep study. And I always explain to kids, even though this looks very intimidating, there's no needles involved, there's nothing that's painful to them. It's just a lot of stickers and wires and monitors everywhere to be connected to. And some parents will ask me, well, do you put my kid to sleep? Are you going to give him medicine to make him sleep? And the answer is, of course, no. I don't want to sedate the child because that can alter their breathing pattern. But almost all kids sleep eventually in the sleep lab. Sometimes it takes them a little while to fall asleep, but the need to sleep is a powerful one. And it's eventually they usually fall asleep even connected to all this stuff. This is like way more granular than anybody needs to know unless you're a sleep doctor, but I thought I would pull it just to show you what obstructive sleep apnea looks like on a sleep study. This is 60 seconds worth of data from a sleep study. And for the sake of time and boredom, I'm not going to go through every single line here and what they mean, but hopefully y'all can see my mouse here. These two blue lines are the airflow sensors. Okay, and the light blue lines below it are the chest and abdominal wall belts, the chest and abdominal movements. And the chest and abdomen should rise together and should fall together when a child breathes. When we see them moving apart from each other, that's a sign of increased work, what we call increased work of breathing, or paradoxical respirations. That child's working hard to maintain patent airflow. So what we see here is that the two airflow sensors, they just flatline completely for about 12 seconds. And then up here is the oxygen monitor, or the pulse ox, and their pulse oximeter drops from 98 to 94 before it starts to recover. So this is a very classic obstructive apnea on a sleep study. And you can see this little red R in the background means the child is in REM sleep, or rapid eye movement sleep. And that's when obstructive apneas are most likely to occur because we lose muscle tone. So let's talk about ventilatory support. This means things like CPAP and BiPAP that we can use to help them breathe when they sleep at night. And sometimes eventually during the day, some kids, as their neuromuscular disease progresses, use daytime ventilatory support as well. So the goal of non-invasive ventilation, so invasive ventilation just means through a tracheostomy, through a tube in the neck. Non-invasive means through a mask that they wear at night. And most people are familiar with CPAP or BiPAP because a lot of people have a mom or a grandma or something that has sleep apnea and wears BiPAP to sleep or something. But the goals in patients with neuromuscular disease are to prolong their survival by improving their gas exchange, so maintaining normal oxygen and carbon dioxide levels as long as possible. And there's actually very good data that use of BiPAP with sleep can prolong survival in these patients. We want to relieve their symptoms. If they have shortness of breath symptomatically, we want, of course, to relieve that so they can sleep better. We want to allow for the normal gas exchange, oxygen in and carbon dioxide out. We want to treat any obstructive sleep apnea that may be there. Improve their daytime function through improved sleep quality. So as we all know, sleep affects everything. It affects your ability to perform in school, to engage in healthy relationships, for older people to perform well at your job. So we want to improve their daytime function through improved sleep quality. We want to prevent the development of heart failure that can happen if they have untreated sleep apnea or abnormal oxygen and carbon dioxide levels for many, many years over time. They can develop heart failure, so we want to prevent that. And we also want to support their growth and development. So we know that kids who don't breathe well, they just tend to not grow well. You know, normal oxygen levels are necessary for everything. All of your organs, you know, your brain, your kidneys, your liver, all of your heart, of course, all need oxygen to function properly. So by maintaining normal gas exchange, we support their growth and development. There are some studies to show also that using non-invasive ventilation at night can actually help with daytime carbon dioxide levels. So even kids who have abnormally high carbon dioxide levels during the day, if they're not using their machine during the day, but they're using it at night, at the beginning, it can help with the daytime carbon dioxide levels as well. And then eventually, many years later, over the long term, it may not be as effective anymore, and then they need non-invasive ventilation during the day also. But initially, just nighttime use is enough. And the use of non-invasive ventilation has been shown in multiple studies to reduce frequency of hospitalization, so reduce how often these kids have to come in the hospital with respiratory illnesses and improve survival. There are two main modes of non-invasive ventilation that I use in patients with neuromuscular disease, I would say the most common is probably BiPAP, and BiPAP stands for bilevel positive airway pressure. So what this is, we set an inspiratory pressure called an IPAP and an expiratory pressure called an EPAP. So the machine is supposed to sense the patient's breathing, and when the child breathes in, it ramps the pressure up to the IPAP or the inspiratory pressure, and when the child breathes out, the pressure kind of decreases down to the EPAP. It also allows us to set a backup rate, which means if the machine senses that the child is not breathing for however many seconds we tell it, then it has the ability to give the child a breath. So if the machine senses this child hasn't taken a breath for 6 seconds or 10 seconds or whatever we set, then it will deliver a breath by ramping the pressure up to the IPAP. So you may see the settings written this way. If your child is on BiPAP, you may see the doctor order it like this, where it'll say, for example, 14/6. This means the inspiratory pressure is 14, the expiratory pressure is 6, and the backup rate is 12. That means we want the child to get at least 12 breaths per minute. And if the child's breathing less than that, then it'll go ahead, the backup rate will kick in. The other type of non-invasive ventilation I order pretty frequently in kids with neuromuscular disease is called AVAPS. This stands for Average Volume Assured Pressure Support. It acts very similarly to BiPAP, but the difference here is that we can set a goal tidal volume with each breath. So with BiPAP, you set the pressure, and the pressure ramps up to the IPAP or the inspiratory pressure. And however much volume of air the child gets with that breath, that's just how much they get. There's no controlling the volume. It's just however much they can get with that much pressure. With AVAPs, we can set a goal volume. So I can say, based on this child's age and size and weight, I want them to get, for example, 300 milliliters of air with each breath. And I can tell the machine that I want the child to get X number of milliliters of air in each breath. And the machine can adjust the pressure within the range that we set as needed to guarantee the volume, the goal volume that we want them to get. So this graphic is kind of advanced and took me a while to understand it, but we can set an inspiratory pressure minimum and an inspiratory pressure maximum. So for every breath, the machine's going to deliver somewhere within this range to achieve the goal volume. So what we see in the bottom part here is with the first breath, the kid achieves their goal volume. Great. The next breath, for whatever reason, they don't. Maybe they're not working as hard to breathe anymore. Their respiratory effort decreases. They did not get their goal tidal volume. So the machine senses that, and it's going to gradually ramp that inspiratory pressure up, staying within the range of the dotted lines here, but it's ramping that inspiratory pressure up until the kid gets back to their goal tidal volume. And that's a little advanced, but these are just kind of a brief summary of the two different types of ventilation that I use most commonly in kids with neuromuscular disease, BiPAP and AVAPs. There are a million different masks on the market for BiPAP and AVAPs, and these are only a few of them. And I show this just to demonstrate a sample, but there are many, many more than this. There are general categories. These ones that go just over the nose, these three on the left that go just over the nose, we would refer to as a nasal mask. Then the one that goes over the nose and mouth like this, we would refer to as a full face mask. There are some that sit up just kind of in the nose, these soft little cushions like this in the middle. This is called a nasal pillows mask. So this lady on the bottom has a nasal pillows mask. This man has a nasal pillows mask as well. You can see there are a lot of different headgears out there on the market. This one goes up just around the ears, so it doesn't have to strap behind the head like this one straps behind the head. This is what we would call a hybrid nasal pillows full face mask. So it has the nasal pillows and it also goes around the patient's mouth. And this child has a whole face mask, or sometimes they call this a scuba mask. And one mask is not better than the other. It's really whatever the child finds most comfortable or most tolerable. I do worry about in kids who are too weak to remove the mask themselves. I prefer to not cover the mouth. And the reason is if they were to have, for example, if a kid gets a stomach bug or they've been vomiting or retching, if they were to need to throw up and they threw up into the mask covering their mouth, there's a risk of that air pressure shoves that vomit back down into their lungs and can cause an aspiration pneumonia. So For that reason, in kids who are very weak, I prefer to use nasal masks because it reduces that risk of aspiration should they need to throw up. And I always tell parents, if your child is on a full face mask that covers the mouth and they have been sick with a stomach bug or something, it's much safer to just leave the BiPAP or the AVAPs off that night. Okay, I think I just have 2 more slides showing a couple of interfaces. This is a teenager with Duchenne who is needing daytime ventilatory support. So he uses this day and night, and you can see they have this whole setup where the tubing goes up and over the head, down behind the wheelchair, and then the vent sits on a hook at the back of the wheelchair. But this allows his range of sight to be clear. He can still talk and engage with his environment because he has just the nasal interface. And this is also another patient with Duchenne muscular dystrophy, and he's using something called a sipper valve, which we use often during the day. This would not be useful at night because this requires patient interaction and cooperation. So it wouldn't work during sleep, but during the day, this is just a little valve that you can see is set at an angle so he can reach it easily with his mouth. And then the tubing goes back behind the wheelchair and the vent sits on the wheelchair. And anytime he feels short of breath or feels like he needs a breath, he can just kind of lean and suck in a little, and the machine senses that he's sucking in and will deliver a breath to help expand the lungs. The complications of non-invasive ventilation are, honestly, they're relatively few. It's very well tolerated. It's not, it's not medicine. It's not even oxygen. It's just the same air that you and I are breathing right now, just concentrated at a higher flow rate to help open the lungs and expand the airways. Some of the complications we do worry about, specifically in neuromuscular disease, we worry about inadequate triggering because, I mentioned the machine will sense when the patient is trying to breathe in and ramp that pressure up. And when they breathe out, it ramps the pressure down. But if the child is very weak and is not able to really generate much inspiratory pressure, the machine may not even recognize that that child's trying to take a breath in and support that child's breath by instilling the air. So the trigger is the patient's ability to take at least enough of an inspiratory pressure that the machine at least recognizes that they're trying to breathe in. An adequate mask fit is very necessary, of course, to maintain adequate support. So if the mask doesn't fit properly and air is leaking out around the side of the mask, it can irritate the eyes and be very uncomfortable to the patient, in addition to just not supporting them adequately, because of course we need the air to get delivered down to the airways, down to the lungs for it to do its job. Some patients will complain of this feeling of bloating because some of the air goes to the stomach as opposed to just to the lungs. Some of it goes down to the stomach as well, and this sensation of swallowing air. I haven't heard this complaint much, but it does happen. Skin irritation can happen from the mask. There are a lot of different liners and protective things that we can put on the skin to help prevent skin breakdown, but that's something we see occasionally, especially in kids who are really good about wearing their mask all night, every night. They can get some skin irritation. You can get orthodontic problems in kids whose jaw and mouth is still growing and developing. A lot of times the nasal masks sit right here on the upper teeth, and so the pressure from that mask can kind of prevent the jaw and the teeth from growing and developing properly. And kids who start using these machines at a very young age can kind of develop a flat mid-face from its use, because the pressure from the mask itself, if they're starting to use it at age 1 or 2 and they use it every single night for 12 sometimes hours a night, young kids sleep a lot, right? So the pressure from the mask over the long term can impair the face from growing properly, and that's what has happened with this child here. You can see everything is very flat through the middle of the face. In summary, children with neuromuscular disease experience a predictable progressive weakness of the respiratory muscles that can lead to impaired cough strength, difficulty clearing mucus from their lungs, swallowing difficulty or aspiration. They have a higher risk of atelectasis and pneumonia, and they eventually will need nighttime and then sometimes daytime support for their breathing, what we call hypoventilation. Early intervention has been shown to prevent complications and prolong survival. So again, my goal is to start these therapies before kids are having problems. We want to see them on a regular basis in the office, monitor their lung function, and start the intervention before they're having complications. If there is evidence of hypoventilation or other sleep disordered breathing, then we start with ventilatory support at night, and eventually they may need it during the day. And coordinated multidisciplinary care is really important, I think, to improve their care and quality of life. So I try to stay in touch with these kids' neurologists and their cardiologists, and sometimes they have GI doctors and their nutritionists, and I want to make sure we're all on the same page about the treatment plan and the best care for these kids. This is a list of my sources, and I'm gonna stop sharing my screen and see if anybody has any questions or comments.
Well, thank you so much, Dr. Caraballo, for that amazing presentation. And thank you again for participating today. And thank you for all that you do for the neuromuscular community. I do see that there is one question in the chat box. So I'm just going to go ahead and read that out loud right now. We have a question of, can melatonin be used on the sleep study?
Oh, good question. And yes, this is something we do encourage sometimes. Melatonin does not, should not, and it has not been shown in studies to affect a patient's breathing. So I don't want to use a sedating medicine that's going to affect what we see with their oxygen and carbon dioxide. But melatonin is totally fine. Depending on the age of the child, we recommend in a young kid, maybe 1 milligram, in a school age child, 3 milligrams, and an adolescent, no more than 10 milligrams. But melatonin is a perfectly reasonable option to help your child get to sleep in the sleep study. Great question.
Awesome, thank you. And then I'm just gonna wait a few more moments, see if there's any other questions that come up in the Q&A box.
Sure.
And if not, then we will conclude.
Thank you so much for having me.
All righty, well, thank you so much for your participation in this event, and thank you for being our last speaker to close it all out. Again, we really appreciate all you do for the neuromuscular community, and thank you again for showing up today and presenting amazing information. So thank you so much.
You're very welcome. Thank you.